This is Unit 5, Alterations in Immune Function, the cancer lecture. The first couple of slides, I am going to let you read yourself. You're not going to be tested on it. It just talks about incident rates and stuff like that. One thing I do want to touch on is that mortality rates have decreased almost 50% since 1975. And that is obviously because we have gotten better at screening tools and at treating the disease. Again, you can read this to yourself based on childhood cancer. So cancer, the etiology, you're going to have external stimuli. So you're going to have carcinogens. And then there's also secondary cancers, which are a result of a primary cancer. So you're going to have chemo or radiation therapy to get rid of that primary cancer, and then 5, 10, 15 years later, you might develop another cancer that's actually a result of the first cancer's treatment, because obviously chemotherapy and radiation kill your cells and change your cells. It also is caused by the immune system and gene abnormalities. So viruses change the immune system, and some people, or some studies have shown that some cancers are linked to viruses, that after your body is exposed and that change in the immune system changes your cells forever. They're obviously familial or gene causes. There is an AML gene marker. There's obviously the breast cancer marker, and then chromosomal abnormalities. So if you have Down syndrome, you're at an increased risk to get cancer. Pediatric differences between adult cancers is that it has an embryonal origin, and so basically it comes from the embryonal nerves, versus in adult cancers it usually rises from the epithelial cells. In pediatrics, they have an immature immune system, so they cannot get rid of mutated cells as well as adults can. And then they are in a constant state of rapid growth, so their cells are changing and growing so rapidly that sometimes the body can't keep up with it. Another difference is that their cancers tend to start deep in the body, like in the abdominal cavity, and that a lot of times the cancer is farther along or pretty big before we even catch it. So these involve the clinical therapies. These are all of them, and we're going to talk about them individually. So surgery can be used as a diagnostic tool. They're going to do pathology. They're also going to look to see if it has metastasized to other areas, how big it is. They're going to take cells from around the cancer to, again, do staging and see how much it has metastasized, if at all. It can also be curative, like with a Wilms tumor. It is rare that surgery is curative, but it can be. Palliative is when they go in there and they know that they can't get all of it, but they may be able to improve the quality of life, so they're still going to do that surgery. A second look is after chemo and radiation, and they're going to look and see what affects the chemo and the radiation had on the tumor, if any. Radiation therapy, it destroys the cancer cells in the localized areas. It obviously damages both the normal and the cancer cells, just like chemotherapy. And external radiation is the most common in children. Side effects obviously are burns or skin abnormalities where the radiation is targeted at. Internal, it really depends on the kind of cancer that they have. You know, if they have cancer in their knee, they're not going to develop neuro side effects from radiation, or they're not going to develop nausea, but they have cancer in their abdomen or in their brain and they're doing radiation, they are probably going to have neuro side effects and nausea and stuff like that. Long-term side effects are, we talked about earlier, secondary cancer. They may experience growth issues and cognitive development delays. Chemotherapy is a use of a cytotoxic drug to treat the malignant disease. It again kills cancer cells by destroying the cells and preventing the cells from dividing. It does not differentiate between the good cells and the bad cells, so it kills all of the cells. If they are receiving an intrathecal, which means into the spinal column, they can also have cognitive delays or impairment because it's crossing that blood-brain barrier. There is cell cycle specific and cell cycle non-specific chemotherapies. And typically the side effects of chemo are due to the good cell death, not to the bad cell death. It's most destructive, chemotherapy is most destructive to the rapidly producing cells in our body. So those occur in the GI tract, in the bone marrow, and in skin and hair. And so if you think about the GI tract, that's why they develop stomatitis or mucositis and nausea and vomiting. The skin, that's why it may become thin or brittle. Hair with the alopecia, the bone marrow with neutropenia, anemia, thrombocytopenia, all of those. That is why they develop all of these things, because those are the rapidly reproducing cells in our body, and that is what the chemotherapy tends to kill. We just went over most of these side effects. You probably remember talking about nadir in your earlier classes, hopefully. Nadir is when about 10 to 14 days after they get their chemo dose, that's when their bone marrow is the most suppressed, and this is when you want them to stay away from crowds and avoid fresh fruits and vegetables, avoid those sick family members. This is typically when they are coming into the ER or into the hospital because they're having a neutropenic fever. We're going to talk about hemorrhagic cystitis, neurotoxicity, and tumor lysis syndrome coming up. Continuing on with the chemo side effects, for alopecia, you want to keep that haircut short because it may look a little bit thicker and fuller. Once they do fully lose their hair, you want to prevent sunburn. So be sure to put sunscreen on their little bald heads. Some chemos also cause photosensitivity, like methotrexate, so they're more at risk for sunburn. So again, be sure and either use a hat or use sunscreen. Honestly, it is drug dependent on whether or not they will lose their hair, and their hair typically regrows back in about 3 to 6 months, and it can come back completely different than it was before. I don't really know. I guess it's because the chemo can drastically change those hair cells or those rapidly producing cells. My mom did have pancreatic cancer when I was growing up, and I'll never forget, she used to have like straight black hair. And then after one of her chemos, her hair came back and it was really curly and kind of blackish grayish. So it definitely changes something about the hair, and she got a kick out of it. Sometimes it's the little things in life, but chemo side effects, continuing on, you have nausea and vomiting. This is really, you want to talk to the patient about what their preference is for liquids and what they prefer for meals. Some prefer carbonation when their stomach doesn't feel well. Some don't want carbonation because it makes it feel worse. So you want to ask them about that. You want them to rest before meals. You might not want them to lie down after they eat because it may come straight back up. You want them to eat small meals throughout the day. It's going to be difficult. Eating is really difficult for people that are on chemotherapy. Here are some more interventions. Maybe try freezing their favorite beverage so they can act like it's a popsicle. Like I said, you want them to sit up, and if you guys have ever been nauseous or had a GI bug and eaten your favorite food before and then vomited, you know that you don't want it again for a long time. So try to avoid those favorite foods when they are in the hospital, even though, parents want to do whatever they can. Giving them their favorite foods might make it worse because they'll never want that food again, or at least for a long time. Again, for nausea and vomiting, here are the medicines that you can give. Zofran obviously is the most common, and it is usually scheduled 30 minutes before that dose of chemo, and then it's probably scheduled continuously throughout their chemo doses. Dexamethasone is a steroid, but it does have antiemetic effects. Lorazepam is Ativan, and sometimes you'll see it ordered. And most people aren't really sure if it is an antiemetic or if it's just because it knocks people out. Adolescents tend to prefer Ativan prescribed for them. You may see Benadryl prescribed for the same thing, but can you really blame them if they're going through chemotherapy that they would like to get some sleep? Chemo drugs that cause nausea and vomiting. There is a chart in your book of pages 619 to 620 that goes over the drugs. I will post this to Blackboard because I did say at the beginning that you didn't need to buy a book. But these really go over the drugs well. And also on your course pack, there is a list of drugs that you are expected to know. That most of them are on the slides at some point, so I'll go over them, but there are a couple on there that aren't on the slides that you are expected to know. Yeah, so all of these can cause nausea and vomiting. And then with the bone marrow suppression that is a result of the chemotherapy, you're going to be neutropenic because you're going to have a decrease in those neutrophils or white blood cells, which increases your infection risk. So you want to watch out for neutropenia, which can lead to septic shock. And it can actually, in children, adults too, it can lead to septic shock very quickly. But even in children, it's been known that from that first sign of a fever to actually them dying from septic shock can only, can be a pretty short time window of about 24 hours. So the parents are educated on bringing them in if they have a fever or anything like that. Anemia, their red blood cells are decreased, so they're going to be very tired. They may get blood transfusion as well. They're going to be at a risk for bleeding, so we do not puncture their skin. If they have a central line, we do access that with the Huber needle. We can't get around that, but we only change that once a week for infection risk, but you don't want to stick them more than you need to. You're not going to give them any IM injections, all of this because of a risk of bleeding. And then I talked about risk of infection with neutropenia as well. Already talked about most of this. You want to make sure that they have good oral care. Use a soft brush. Avoid activities that may cause injury, because if they are neutropenic and they get injured, they're at a higher risk for bleeding and it's just going to end badly. So they also want to avoid contact sports. You don't want to give aspirin and you don't want to give ibuprofen when their platelets are low. As a rule in the ER, we typically don't give ibuprofen to hem-onc patients in general. This is because it can cause platelet destruction and then it can also cause GI bleeds. So we tend to stick to Tylenol, which you can do IV Tylenol as well. Continuing on, you want to, most children who are getting chemotherapy are going to be on neutropenic precautions, which means they're going to have a private room. They will need to wear a mask in the hallway. For us, we just need to use standard precautions when we go in. But they can't have fresh flowers or fresh fruits or vegetables or anything like that. You want to use an aseptic technique when puncturing the skin if you have to. Restrict visitors, certainly, if they are sick. You may give the GCSF, which is based on protocol. That stimulates a white blood cell production, so hopefully will increase their white blood cells and increase their immune system. This is typically given around the nadir period, but again, the hospital will have a protocol based on it. Chemo drugs that cause bone marrow suppression are listed there. With methotrexate, the rescue drug is leucovorin, which is important that you know that. It is scheduled. You cannot give it late. If you give it late, it's not going to have the same side effects. And basically, the goal of leucovorin is to save some of the good cells so that you're not killing off all the good and the bad, but hopefully that you can save some of those good cells. I have briefly talked about how it can result in septic shock. If children with cancer who are getting treatment or not develop a fever and it's more than 100.5, this is a huge concern. The parents are taught that it is a huge concern and that they need to be aware of their child's temperature. If they develop this fever at home, they need to go to the clinic right away or go to the ER. What's going to happen is you're going to draw blood cultures right away. You're typically also going to draw a CBC to see what's going on with their hemoglobin and their platelets and everything. And then you want to start those antibiotics stat. It is a priority to prevent septic shock. We had a protocol in the ER that you wanted to get antibiotics in within an hour, which can actually be a challenge if you're thinking about getting a child into a room, getting access. If they don't have a central line always, then you got to get an IV in them, and sometimes they're a hard stick, and then get those antibiotics going. But you want to get them done as quickly as possible to prevent septic shock. So another side effect tends to be GI ulcerations, stomatitis, or mucositis. You want to avoid giving or taking rectal temperatures and giving suppositories because it can rip that rectal mucosa, which can cause bleeding. You want to do good hygiene to the rectal area, give a warm sitz bath, avoid acidic foods. Mouth care, mouth sores are a huge problem. In these patients, it can actually result in an admission, and they're going to get hydration and pain management because of those mouth sores. So it can be extremely painful for them. They may even be on a morphine PCA because of mouth sores. You definitely want to read through all of these because these are nursing interventions. I'll talk about glutamine briefly. That stimulates amino acid production, which can prevent mouth sores, so you may see that ordered for some patients. Chemo drugs that cause GI ulcerations are methotrexate and dactinomycin. Hemorrhagic cystitis is another side effect of chemotherapy. It is, if you think about it, that chemo is going to be filtered through your kidneys and excreted through the kidneys and then sent to that bladder. And it's going to cause irritation to the bladder, which is secondary to that chemotherapy. This is huge for anybody who's on chemotherapy, not just because of this, but because of all of the other side effects. But you want them to drink fluids and you want them to be well hydrated to prevent hemorrhagic cystitis. It's going to prevent that urine from sitting in the bladder too long and irritating that bladder. You want them to void as much as possible. You know, as soon as they think they need to go, they need to get up and go. They don't need to be like nurses and hold their urine for 8 to 12 hours at a time. You want to make sure that they void before they go to bed, and then try and get them up at least one time during the night, and then make sure they go first thing in the morning. Again, so that urine isn't sitting in that bladder with that chemotherapy. You want to try and give the chemo early in the day so the patient can drink fluids and we can flush out their system throughout the day. That doesn't always happen in the hospital. Certain chemos that can cause it are Cytoxan and ifosfamide. Typically, if you're given Cytoxan, you are going to give Mesna. And just like leucovorin, it is scheduled and needs to be given on time. And this Mesna is going to provide bladder protection so that hopefully you don't get hemorrhagic cystitis. Some other side effects of the treatment. On this slide in particular, I want you guys to think about what we can prevent and fix versus what is permanent. Like jaw pain, we can fix that. Constipation, we can fix that. Typically, they're going to be on a bowel regimen because they're going to be on pain medicine. So they're going to be on a stool softener at minimal, maybe on Miralax. But if they develop learning difficulties due to chemotherapy or radiation, we can't necessarily fix that. If their extremities become numb, it can be permanent or it can be transient. So you just need to think about, you know, what we can help with and what we can't help with in terms of neurotoxicity. The chemos that typically cause neurotoxicity are listed there. Tumor lysis syndrome is another side effect of chemotherapy. So when you're giving chemotherapy and we're destroying those tumor cells, it causes a release of high levels of uric acid, potassium, and phosphates into the blood. And so the patient may develop cardiac arrhythmias because of that potassium. They may actually go into renal failure because of this. So again, hydration is extremely important. And you are going to have bicarb in the fluids to counteract that uric acid. You may give allopurinol, which is typically, you may have seen it in adults, which is also given in gout. But it's typically given in leukemic and lymphoma, but not all types of lymphoma. But it blocks uric acid production. I do want to talk briefly about the renal failure and really about before they get chemo at all. It's important that you establish baseline renal function before you give them chemotherapy, because if they don't have good functioning kidneys before chemotherapy, they certainly are not going to have good functioning kidneys afterwards. So you want to establish kidney function before the chemo or before you give them you know, bicarb or potassium in their fluids or anything like that. You want to make sure that their kidneys are functioning properly. You also want to, you're probably going to get a baseline EKG because it can affect their heart function. You're probably going to get a chest x-ray because it can affect their lungs. You're just going to get a bunch of baseline labs and tests before you even start that chemo. Biotherapy, it's not going to be on the test, but this is a newer form of treatment. It is targeted cancer therapy based on biological retooling and molecular intervention. And so, you know, there's a lot of research out there about cancer vaccines and developing one. HPV would be the closest thing we have to anything that affects cancer currently, but this is kind of the next phase probably of cancer research is biotherapy. They may some of these patients may end up needing a bone marrow or stem cell transplantation, especially in leukemia. If they have AML, pretty much once they go into remission, they're going to go off to bone marrow to get a transplant. If they have ALL, which is, they're not going to, it's probably not going to be their first line of defense if they go into remission. But if they relapse, they may then go off to bone marrow and get a transplant. In neuroblastoma, there are different kinds of donors. You can be a donor to yourself, where they actually remove yours and then re-inject it into yourself. You can have a donor, so not yourself, to donate stem cells, and then cord blood banking is available for newborns that they can pull that cord blood and give you a bone marrow transplant from there. So leukemia is the most common type of cancer diagnosed in children less than 14 years of age. How it works is the bone marrow produces immature white blood cells, which are lymphoblasts, which are cancerous. And then you don't have enough normal functioning cells of the bone marrow, so you're not going to have enough red blood cells or platelets or white blood cells. So ALL is the most common, and then AML also is a type of leukemia. I kind of already mentioned that the cells will divide rapidly and they crowd out the normal cells. So the bad cells are crowding out the normal cells. And again, it usually results in pancytopenia, which means decreased red blood cells, decreased platelets, and decreased white blood cells. Clinical manifestations basically are the same as any bone marrow suppression signs and symptoms. You're going to have fever, pallor, bleeding. You're may present with petechiae. You may have lethargy or malaise. You're just not going to have a lot of energy. You may not want to eat. And they go on down to even central nervous signs and symptoms such as headache and vomiting. Clinical manifestations typically, like I said, involve the central nervous system, and it is a very common site of metastasis to the central nervous system, as well as testes are also a common site of metastasis. So diagnosis, you're going to do a CBC with a differential. This is actually usually drawn at the PCP, and a lot of times in the ER we would get transfers, of a child who had labs drawn at the primary care doctor, and then they're sent to the ER to have the labs repeated because they were so abnormal, and they would be admitted to HEMONC and be told they had cancer and go from there. You may actually see in the CBC that their white blood cells are high, but that does not mean that they have a lot of white blood cells. That means that probably a high percentage are not functioning, so they are neutropenic. They're going to have a lot of lymphoblasts, which are those immature white blood cells, and so again, you're going to have a lot of non-functioning white blood cells. And then the definitive diagnosis is a bone marrow aspiration, typically taken from the iliac crest. This will tell you if it is leukemia and also what kind it is. Treatments, they might do radiation, but all will get chemotherapy. The goal is to gain remission through induction, which means that you have decreased those white blood cells down to only 5% lymphoblasts. Some children may not ever get past this induction phase, unfortunately. They're going to get high-power chemo agents at the beginning, and then you need to realize that their induction phase can be and is typically extremely long. So it's usually a 2 to 3 year treatment. So they may only be in the hospital Well, they may be in the hospital for about 6 months, but even after they're discharged from the hospital, they're still going to be going to the clinic and getting, chemotherapy either intrathecally or through their port or orally. So it is a long treatment phase for them, and it's just a long and stressful and hard trajectory for these children. If they do reach in remission, they're going to be checking that spinal fluid throughout. If they have a relapse, they're going to re-induce them again to get those lymphoblasts down. They can't do the same chemotherapy again, which is when it gets complicated because obviously the first chemotherapy didn't work. And then we still consider remission of 5 years equals a cure. The prognosis is much improved in leukemia, and we talked about earlier in the slides, because we have better diagnostic tools, and then we have better treatment and better medications to treat the side effects. The onset is typically between 2 and 10 years of age. The initial hemoglobin is usually less than 10. They may have a low initial white blood cell count, but we also talked about how it may be high, and that is not necessarily abnormal. Hopefully, they're going to have a quick response to chemotherapy. AML has a much worse prognosis than ALL. I think there's only like a 50% survival rate for AML, and it counts for 17% of leukemias. This is another type of cancer, Wilms tumor nephroblastoma. It's an intrarenal abdominal tumor. It's most common between 41 and 47 months of age. It attaches to the kidneys, and it's stage 1 through 5, just like most cancers. Clinical manifestations, they're going to have an asymptomatic, firm, lobulated mass in the abdomen, and it is usually unilateral. They may have hypertension in about 25% of the cases. This is because sometimes the tumor gets so big that it's pressing on the aorta, so it's going to cause hypertension. They may have blood in their urine and abdominal pain, not always. This is the most important, is that it is encapsulated, and so typically the survival rate's pretty good because you can remove that tumor and it has typically not metastasized because it is encapsulated. However, it's important in nursing care and parents and everybody. You don't want to palpate that abdomen because it isn't encapsulated. And if you palpate that abdomen too much, you may break that capsule, and now you have just caused that cancer to go everywhere and it has metastasized. So be careful when you're giving them baths, and you certainly don't want to cause any trauma. Again, educate the parents, educate yourself and the nursing staff as well. Diagnosis, you're going to do an abdominal ultrasound. You may do a CT or an MRI of the lungs, the liver, and the spleen to look for metastasis, but like I said, most of the time it hasn't. You're going to do a CBC, see if it's gone into the bone marrow. You're going to check out those kidneys to see what's going on with it. You're going to check out the liver as well. A tumor biopsy is obviously the definitive diagnosis. Again, the prognosis is good. These are the treatments for it. Hopefully they'll do surgery and just remove it, and they won't have to do anything else. Last but not least, we have neuroblastoma. This is a poor prognosis because it is typically metastasized to the brain by the time we find it. It is a solid tumor outside the cranium, like I said, but it has typically metastasized. It starts outside the cranium, but typically has metastasized into the brain. The average age of onset is 2 years, but in most cases are diagnosed before age 5. There are stages 1 through 4. The survival rate for stage 4 is only 22%. And the main issue of why this is a poor prognosis, it's kind of like pancreatic cancer. Most aren't picked up until it's at least a stage 3. And still most are at a stage 4 by the time they found it. So it's by the time they found it, it's metastasized, and there's not a whole lot that you can do for it, unfortunately. This is one of those cancers that originates in those embryonic nerve cells like we talked about at the beginning. This is most frequently arises in the abdomen, and this is also another issue because it tends to be deep in that abdomen. Other sites include the adrenal, thoracic, and cervical areas, but again, they can be deep and not found for a while. Clinical manifestations really depends on the location of the tumor. Obviously, if it's adrenal, you're going to have different side effects or clinical manifestations as opposed to the cervical area. You're going to have weight loss. Their abdominal area is going to be full. It's going to be distended. They're going to be irritable. They're going to be tired. They're going to have a fever. They're going to probably have bone pain or even a limp. The bone marrow is typically involved once it crosses that blood-brain barrier. So again, they're going to have pancytopenia. If it is a mediastinal tumor, they're going to have dyspnea, and they're going to be at risk for infection, and they may have neck and facial edema. So the respiratory assessment is important if it is mediastinal because you want to assess what's going on with their lungs. And they may also have hypertension because of that involvement. They may have retroperitoneal, and so you'll have bowel and bladder side effects as well. Diagnosis definitively is a tumor biopsy, and then they may do urine or serum catecholamines. The two listed are specific to neuroblastoma, so if you have those in your urine or in your blood, then you have neuroblastoma, and so they will routinely check your urine and blood for these catecholamines, and it can also be an important marker of recurrence if by some miracle you go into remission. Tests for metastasis, the same as all the other ones. You're going to do a bone marrow aspirate, a bone scan. You're going to look at all of their bones, skeletal radiograph. You're going to do a CT or an MRI to see where it has metastasized, a spinal MRI. You may do a chest x-ray as well. And then clinical therapy depends on the stage, and it depends on the severity. They're going to do surgery, chemo, radiation, all three, none. Neuroblastoma is a nasty type of cancer, and it is very sad. And typically, if you ask anybody who works in HEMONC what they wish or want, they would want a cure for neuroblastoma. Obviously for all of them, but neuroblastoma tends to, there's just such a low survival rate, and yeah, it's very sad. So that is all. Let me know if you guys have any questions.